delighted to be presenting Collective Impact, Health Equity, and Public Health, this webinar with you. The presenters and myself have had interesting discussions in putting it together and are looking forward to sharing it with you. Please let us know if you have any technical difficulties. Please use the chat box, which most of you have found there, just to ask questions, give resources, and also let us know if you're having any difficulties. I'm Karen Fish, and I'm being very ably supported here today by my colleague Danielle McDonald. I just wanted to note that Karen Fish too in the chat line, but she said she'll write her name in just to indicate that it's her. So our advisors today, we have 3 advisors who are all very experienced in public health and collective and engagement with collective impact. Petra Chambers is a collective impact consultant living on Vancouver Island. She was formerly coordinator of the Child and Youth Health Network of Vancouver Island, one of the stories featured in our recent publication. And she has worked across sectors to improve health for 25 years. Louis Sorin is, among other things, chair of the NCCDH Advisory Board, and he is CEO of End Homelessness Winnipeg. He was formerly a community area director with the Winnipeg Regional Health Authority. Hannah Moffat is public health equity initiative leader with the Winnipeg Regional Health Authority. She was formerly a knowledge translation specialist with NCCDH and is still missed. So we'll be exploring these 4 topics today in the webinar. The first is the evolving CI framework. We won't give a lot of detail about the framework. So there are lots of resources you can go to for that, but we will talk a little bit about its evolution. We'll look at where public health is, where and how public health is getting involved. Each of the speakers will speak to the personal and organizational tensions involved when public health gets involved in collective impact and collective impact initiatives. And we'll look at the conditions for effective public health involvement. And once again, we welcome your comments and questions throughout the webinar. We'd be delighted if you would come on the phone line during one of the discussion times. To do that, you have to be on the phone line. So you have to go back and check the phone line. I'll just run it back here in case any of you would like to shift. This is the teleconference and code number that you'll need to use if you want to speak online. As many of you already know, the National Collaborating Center for Determinants of Health is one of 6 collaborating centers located in 6 different regions of the country. And our focus is to provide the Canadian public health community with knowledge and resources to take action on the social determinants of health and to close the gap between those who are most and least healthy. So health equity is essential to our focus. As I said, we will not be giving you a lot of detail about the conditions and principles of collective impact today, but this is a brief overview. The concept of collective impact was first articulated in 2011, so not that long ago, in an article by the founders of the social innovation consulting firm FSG. And Danielle will put the link to that article in the chat box. The Tamarack Institute has been Canada's go-to resource for collective impact. It defines collective impact as an advanced form of collaboration that brings together different sectors to work on a common agenda to solve large, complex problems. So partners coordinate their efforts across sectors rather than working in isolation. And 2011, there's been a groundswell of interest in collective impact, and I think our speakers will address that, what collective impact has given people who are already working very much across sectors and in collaboration. So this slide shows the 5 conditions of collective impact: common agenda, shared measurements, mutually reinforcing activities, continuous communication, and backbone support. And I put there 2 superb references for you: the Collective Impact Forum, which is organized by FSG and the Aspen Institute, and full of resources for people and organizations. And then the Collective Impact Community of Practice with the Tamarack Institute. And I don't know if we have anybody yet from the Tamarack Institute with us on the line, but they've also been very helpful in guiding us in our work. And they have a community of practice and training sessions and do amazing work in supporting collective impact initiatives in Canada. So, collective impact has been of interest to the NCCDH because these initiatives work to improve the upstream conditions that affect health. And they work particularly on the conditions of people living with fewer of society's resources, so that they address fundamentally inequity. In 2015, we hosted a video conference with 39 participants, both public health and community sector members, from 5 different collective impact initiatives involving public health from across the country, and that sort of started our work in this area. And then this past summer, we published this report, which is a blended case study describing 2 collective impact initiatives in which public health is significantly involved. And our intention here is to promote collective impact as an area of work for public health and to deepen public health staff's understanding of how collective impact can serve the mandate of public health. So the 2 stories that we chose, the child, or that chose us, I'm not sure which way it worked. The Child and Health Youth Network of the Capital Region is an emerging network on Vancouver Island, and this is the initiative that Petra will speak to and was instrumental in. And it has up to 200 member organizations and 500 individuals involved over the past 10 years of its existence. And you'll note that both of these networks, if it wasn't necessarily our choice, but they both are addressing child's mental and physical health. And Ruby Brewer, I don't know if she was able to be on the line today, but she is with the Middlesex London Health Authority, and she has been very key in the work of London's Child and Youth Network. So I just want to, in our report, we give a little description of each of these Canadian initiatives that we are aware of where public health is significantly involved. And please let us know in the chat box if you have been, if your organization has been involved or is involved with a collective impact initiative. We'd like to know, but we're sure we haven't got them all. And I put my email address here. So we're going to slide 11. I'd just like to talk a little bit about what we've learned. We worked on this report with Diana Dagcrofer, who is the consultant working with us, and my colleague Leslie Dyke, who is in France at the moment. And we distilled hours of Diana's interviews into 7 areas of learning. And the report goes into other areas of learning too, but these are the ones I'm going to highlight here. And of course, almost with everything, the first thing that comes up for the need is the need for time. But I guess with a collective impact specifically, which is looking at its best, is looking for large-scale system change, it takes time. It takes time to build trust. It takes time for people to understand what each other is doing. It takes time to learn terms together and to have large group meetings and small group meetings. And for example, it's a Vancouver Island initiative, and Petra might speak to this. It was well over a year before they came to a clear understanding of the common agenda. And one of the things that London expressed to us is that they started to look for some quick win areas. So they looked collectively for some ways that they could achieve something even while this common agenda and measurement work was going on, just to keep people motivated. So then the next lesson was aligning organizational staffing with the CI structure. And London is a wonderful example of this. The City of London provides the backbone support, and the Middlesex London Public Health Unit contributed half the time of a public health nurse, and also the engagement of 17 staff people on various committees and subgroups. And those within the health unit, the people involved in those various subcommittees and the governance committee would meet a few times a year to ensure that there wasn't too much overlap with their own contributions. And then this idea of work for worldview, policy, and organizational alignment. The Vancouver Island Child and Youth Health Network prioritized youth mental health quickly, but Petra explained to us that it took research and some time to select youth connectedness as the highest leverage point to align their activities. I think Petra will be speaking later about alignment, change, and discomfort. And for London, they talked about how the Ontario Public Health Standards help them to align the vision between public health and the collective impact initiative, because the standards identified priority populations and community partnership as priorities. Next slide, slide number 12. Funding is not uncommon, but I just wanted to point out that the City of London, which was the backbone organization of one of those initiatives, contributed $1.1 million over 5 years, and 3 times that amount in kind and other funding. And sort of in contrast, Vancouver Island has really struggled to find funding to maintain its backbone support. It continues nonetheless, but funding can make a big difference. And then continuous network communication. These are common to many initiatives, but given that, for example, London has had up to 200 members, just continuously letting people know through email, Google Groups, electronic newsletters, small meetings, large forums, what's being achieved, what evaluation results are coming in, what kind of measurements are being considered, who's joining and what their work is, those kinds of things is very important. And having a staff person who is at least some time dedicated to the initiative really helps. And then integrated evaluation. So collective impact initiatives look for key indicators to measure their progress. And London, both initiatives looked outside themselves for help in this area. London called on our researcher at Western University to help build the indicators, and he then contributed the time of masters and doctoral students to support the evaluation work. And Vancouver Island called on or was successful in building a collaboration with the McCreary Center in BC to develop its index of connectedness. And then involving people with lived experience. Vancouver Island did a significant amount of work in this area to bring youth into the decision-making tables, and many of the youth who were involved were not quick to engage, and the work was being done to make them feel welcome and to having their voices be heard and responded to. And Petra etc., and others work to find ways to use youth members' experience and facilitation skills and purposefully put topics on the agenda that were awkward but that addressed the issues that youth were talking about. So my final slide before we move to our first speaker is just to point to the work that the Tamarack Institute has done to shift, to look at the evolving nature of the collective impact structure and to shift people's thinking around it from a management model, a collective management model to a movement building model. And there is an article called Collective Impact 3.0 by Liz Weaver and Mark Bash, and Danielle will put that up on the link for you, that talks about this move from common agenda, for example, to community aspirations. So up next is a polling question. So we're just curious, those of you online, we're on slide 14. I'm hoping this will work, Danielle. I should, even with these slides not progressing, but if you could check whether your organization is not contributing to a CI initiative or whether it's contributing money, staff time, behind-the-scenes support, backbone organization. And further, please let us know in the chat box. So lots of engagement at various levels. I'm really pleased to see that. A lot of staff time. Some money. And backbone organization. I probably could have put a public health organization or not there, but that's wonderful to see that. Thank you very much. So our next slide, slide 15. I'd like to ask Louis Sorin if he would speak to us now about his work.
Okay, perfect. And thank you for everyone who's participating in the chat and those who are listening attentively to the materials and the information so far. It's a real pleasure to be on this call. I am, as was introduced, the chair of the board for the Collaborative Center on Determinants of Hope, but I also serve as the president and CEO of End Homelessness Winnipeg in Winnipeg. And so what I'm going to talk about today is about some of our learnings and some of our experiences around creating a backbone organization, and some of our learnings about doing collective impact, engaging in equity work, and what's the potential role and place of public health in all of that, and from our experiences. So the first slide that you see there is that there is a strategy continuum that we always have to consider in first place. And even if we're going to do collective impact, we've got to be clear on how do we want to structure ourselves through our strategic discussions and through our strategic planning. There's some that are at one end of the continuum. There's low certainty, agreement, and stability, and that is really good for emerging strategies. And at the other end of the continuum, there's detailed strategies that really are very, very clear and granular about what we do with. And that's meant to create high certainty and agreement. We found in Winnipeg that even with a detailed strategy that took 2, almost 3 years to develop around homelessness, which is a chronic, wicked problem in our community, we ended up with a detailed strategy, and we almost have to continually recreate the strategy in order to become more nimble and more responsive to emerging issues and stuff. So once the strategy is developed, doesn't mean that it becomes the working plan for collective impact. It's just the starting point. And so if we move forward to the next slide, and there are strategies. The point here is that we have a 10-year plan, but we need elements of each type of strategy if we're going to succeed. So we need containers of change, which is the language of collective impact, where sometimes we need emerging strategies and sometimes we need detailed strategies that are topical and really focused. So here's what we've learned so far about what needs to be a backbone organization, because we're one of the few organizations in Canada that have organization, but what it means to be a backbone organization. I present this information here because you can see in the bullets when we describe in this first slide what it means to be a provider of backbone support. You can see the tensions that exist, that we have to kind of wrestle with and that we have to come to terms with as a community, and what our role is. Someone was teasing us recently saying, if we're not good as a backbone organization, we might end up as a tailbone organization. And so we've got to be careful as to how we, and it's a big shift in our community to have such an organization. It's meant to be transformative, not just to manage the issue of homelessness, but to transform systems and stuff. And it's also an evolution that needs to occur, whereby the community has to be ready. If you're looking at the third bullet there, whereby it has to be based on trust and credibility, and it has to be based on relationships. So when the community, the sector is not currently ready for us to do all the convening, we have to be able to adapt to that and to look at, and it does take time. We've been at it for a year and a half, and we still have lots of work to do. One of the tensions that emerges here is that how do you balance process and results? And increasingly, it's about results. One of my board members said to me yesterday, it's nice to talk about the need for irrigation ditches, but you have to talk while you're digging the ditch. You just can't have coffee over it. And so we have to have results. So we have a complex network of organizations, and we have to respect that complexity and the history that is attached to that complexity. And we have to be able to adapt and bring them into the fold as far as into the conversation about how do we create a strategy that helps them transform their work, not just meets the interests of others in regards to what the work has to be about. Next slide. We've also talked about what's the role of a backbone organization when it comes to funding. And this is a really hot topic in our community when you're doing collective impact. Does funding need to flow through our organization? Do we need to centralize funding? Do we need to have authority over funding in order to find efficiencies? And where is it? How do we look at accountability as far as try to coordinate and integrate the work that needs to occur if we're going to have collective impact? And there is a lot of funding that's actually flowing there. In Winnipeg, we have, as in many other cities, the HPS and other entities that are funding sources. So how do we look at integrating that? And it has to come again about trust within the community before they'll accept us managing things like rent subsidies and other things. And it's always about the relationships that we need in order to succeed and make the change. So these things do take time. And so here's how we've defined our role around funding, and as a board and as an organization with our community. The next slide is that are we provider of service? And what does that mean to be a backbone organization? Because some of at certain levels, some funders would like us to be overseers of direct service, and let the direct service report to us instead of government. And so we've concluded we're at the point where we're seeing that we're not direct service at all, and that offers some comfort and security to those who are in that scope, into that domain. And then but we are in the process, we are in the game when it comes to identifying issues, gaps, and opportunities, and it means building the capacity of the sector in order to do collective impact work, to break down the silos and stuff. And then we're also looking at when there is no other organization, how do we incubate those services and transition them to the community in a sustainable way? So, next slide kind of encapsulates what we've learned about the tensions of doing collective impact and equity work in our community around homelessness. And this is not new to many of the listeners or participants here, is that there's always the product versus process tension. And there's a long-term versus short-term tension, the inside versus outside tension. And these are very real to us. my question and my thought around this is that what is the place within the circle of public health, being established public health entities, or the role of providers and the role of practitioners and leaders in public health in actually doing that work? I can share with you that we have a very strong relationship with the public health sector in doing this work, because there are two things that at least two things that the public health sector, population health, does very, very well. One is surveillance. One is about taking the dialogue from practice into looking at trends and issues and bringing that evidence forward. And so we look to public health to do that with us as a community and within the community. So it's sometimes a new relationship to help around data, to help around evidence, to help around capturing equity data, which is not usually captured elsewhere, in order to create that story about the importance of doing this collectively, and actually introducing the thinking behind equity-based public health to a community of practice and a community of service that may not have had exposure to it or seen the benefits. And as well, in many ways in our community, public health has a very powerful and privileged role of being able to convene people around the table. And when we're talking population public health, we're not talking strictly healthcare here. We're talking about community care. We're talking about all kinds of things whereby public health practitioners, and leaders, managers, and organizations can actually be seen as part of the community. And that's a real privilege. That's a real creates a safety and creates avenues for us to attend to some of those tensions that are existing within our community around doing this work. So I'm not sure where I am on time, but I'm open at this point to move forward.
Thank you very much, Louis. You're perfect on time. I don't know if there's anybody at this point who has a question for Louis. We certainly could take a minute, and if anybody would like to unmute their line and ask a question, you would be welcome to do so. Have somebody typing? I'll wait a minute for that.
If we move to the next slide, slide 21, which is the polling question, I'd be really curious to hear from people around how they feel about public health, about participating in CI initiatives, whether it's core public health work, marginal public health work, not public health work, or other.
Yeah, we've got collective impact fans here, but it still feels good to see that kind of a response.
It's very validating and confirming for me as far as, and I think for others as well. It's also very interesting as to how we define core public health work. And that's part of the tension, right?
So Louis, Darlene Schindel has asked if there's a kind of, I don't know, Darlene, if I'm misinterpreting, but if there's a collective impact kind of work going on among ending homelessness initiatives across the country.
Thank you, Darlene, for that question. I see it here in the chat box. There are many cities, and it's a growing number of cities that are attending to homelessness through an appreciation and a framing and structurally and operationally looking at collective impact approaches to all of this, because they know that is beyond the spectrum of what my first slide was. There's this whole new domain of that's called collective impact that is way deeper, in a deeper way. Our communities coming together, many communities are members or a part public and especially about communities together as far as shared learning, as far as tools and approaches, as far as best practice around that. Every community, though, is unique in its own way as far as scale and depth of issues, scope of issues, and the configuration of services that are available. It's different if you have 40 people versus 2,000 people who are chronically homeless in your community. But there's something to be learned from different cities who are talking about how they overcome some of the challenges.
Louis, there's a question from Irene about how do you get provincial government support for work in this area?
Yeah, in Winnipeg, what we did is we took 2 years to actually develop a plan, a 10-year plan that was based on collective impact. And one of the key messages in collective impact is that there's a place and there's a responsibility for all sectors, for others, for everyone who's touched by the issue to actually contribute. So it's not a question of scarcity of resources, it's a question of social responsibility and generosity when it comes to resources. And what we did through that work is before we even launched the plan, that we had provincial, we had local, we had WRHA, which is health sector, health and social services, and we had the United Way all come together and agree to the plan and support the plan. And part of that support was about supporting a backbone organization. So that is instrumental at the funder level and also at the sector level. Now, having said that, we still need to work with all of them quite closely to actually flesh out what their investment and what they see as part of results for that investment and what they're looking for through that investment. And that might not always be of collective impact, maybe framing collective impact. It might be the interest might be quite siloed. So there's still lots of work to be done.
And maybe Louis, just a minute more, but Jennifer Butcher was saying too that I guess certain conditions needing to be met with a collective impact initiative for public health to engage, and that maybe public health can be working with other collaborative initiatives as well as collective impact, I guess, is her statement.
That's a really
Or I think maybe her question is, when does public health know that there's know to get involved? That's a big question.
Yeah, it's partly knowing when to get involved, and it's partly a self-assessment and a reflection on what public health does and can do moving forward that is framed within collective impact, so that it should be transformative for public health as a sector as well, as much as we're asking other sectors and other stakeholders from private to public to government to local communities and state constituents. We're also looking at how is the practice of public health being transformed by collective impact. So it's a reframing of the work sometimes, and it's also becoming aware and understanding of a whole sector of work that might require public health to be an ally with, and what is the role of being an ally. And also, there's also a bunch of work that's occurring that they need to become much more versed about. There's a whole bunch of work that's occurring in the community that's quite powerful and that they need to be learning from as a community of practice, because that changes everything through those relationships that are based in learning rather than expertise.
You'll keep anticipating the next remark, Louis. Thank you so much for that. And Heather, from the Tamarack Institute, also just made that comment that public health can't do its mandated work on its own. It needs to be working in collaboration. So, I would like to now move us on to the next slide, please, slide 22. Lekwungen territory over here on Vancouver Island, where we're having one last glorious day of summer, and I'm really delighted about that. My background is in community engagement work, measurement, evaluation, and I particularly love working in the area of analysis of complex adaptive social systems. So that's kind of how I got into this work. Today I'd like to talk a little bit about leadership and collective impact and some of the tensions that can arise in that work, and some of those Louis has already touched on and explored in some depth. In my experience, so let's just move on to the next slide here, which says tensions and collective impact as a heading. In my experience, public health has really a pivotal leadership role to play in collective impact for a few reasons. And Louis has already touched on some of these. The public health priorities are naturally aligned with the types of challenges that communities usually try to address through collective impact. Public health, we know, is already focused on system-level change, and it already takes a long-term view and a population-level view. It already sees the value and the necessity of working across sectors. It's already connected to most of the key players and partners that we want to bring together in a collective impact initiative. And importantly, public health has the credibility and the authority to bring people together. And when I say authority, I mean that public health has the respect of communities. That's the kind of authority that I think public health really brings to collective impact work. So it's naturally well placed to take on that kind of leadership role. And as Karen noted, public health and collective impact both share a commitment to working upstream. So there's already a lot of really natural alignment, I think, between the two approaches. So one example, in one collective impact initiative that I have been involved with, public health was instrumental in bringing all the partners together at the outset and continued to provide leadership throughout the entire development of the network. And here locally, it was Kathy Easton, who's a public health manager, who became aware of what was emerging in the region just because of all of her work in community, and she was able to bring everyone together. And that really was the catalyst for the entire initiative. Kathy, because of her role, she was able to understand community need, and she saw the potential of what people were trying to do. She was able to facilitate connection with other key players, both people inside public health and outside public health. And she continued to offer what I would call sort of a transparent and quite neutral leadership, so that the partners who came together to do the collective impact work could really focus on developing the network. And that's the kind of leadership that's really necessary, and it's also the kind that looks really effortless from the outside, but actually requires a very high degree of skill and awareness, and I think it also requires a fair bit of courage. So I'm just going to focus in on that a little bit in terms of leadership roles that public health can take and some of the tensions that can emerge in taking on that role. So leadership in collective impact, it's paradoxical, and I do love that about it. Taking on leadership roles in collective impact means that you get to cultivate tensions inherently, including tensions that a lot of people find really uncomfortable. So on this first slide here, I've outlined 5 tensions that are pretty common, and Louis mentioned some others. He mentioned the tension between process and results, as well as the tension between the long-term work and the short-term work, and also on whether this is core public health work or marginal public health work. And these are also additional tensions that are present when we start to wade into this territory. And I'm sure that Hannah, who is up next, will identify more. So for people who maybe aren't looking at the slides, the 5 I've got up here now are the tensions between ambiguity and effectiveness, what's measurable and what's important, the needs of the community, and then the needs of the systems that are designed to serve it, equity and efficiency, and then my very favorite tension is around whose norms and who gets to feel uncomfortable. So I'll just move through those. If we can advance the slide. Ambiguity and decisiveness is the first one here. So one thing that becomes becomes apparent pretty quickly when we start engaging in collective impact is that we all have different levels of tolerance for ambiguity. Some of us are pretty comfortable there, and others get really impatient really, really quickly. Our culture is all about decisiveness, but often when we start doing collective impact work, we need to enter into a collective state of not knowing first in order to figure out how to do things differently. Because if we act decisively right away, usually we end up doing the same things we've always done or some variation on that theme, and then we get a variation of the result that we've always gotten. And that's not the point of collective impact. We invest resources in this process in order to create sustained system change. And that requires a different approach. That requires that we hold off on decisiveness and court ambiguity a little bit while we figure out how we're going to proceed together. So the tension between ambiguity, or we could call it adaptability, and decisiveness is, I think, an opportunity for establishing a culture of respect and curiosity and experimentation in a collective impact initiative, but only if we as practitioners and as partners and as leaders can find a way to embrace that tension. So if we move on to the next slide, here's the next tension I'd like to discuss a little bit, what's measurable and what's important. And of course, this is a classic tension, and it's certainly not just inherent to collective impact. Shared measurement is one of the 5 conditions of collective impact, and I like to think about measurement as the navigation system for a collective impact initiative. This particular tension can be difficult to manage for public health partners and leaders because the tendency is for measurement to take over. We need to keep returning to what's important, even though sometimes what's important is really difficult to measure. And we also need to be accountable, so that's where the tension comes in. And then you have a struggle with this tension on a daily basis in our work. It's certainly not unique to collective impact. But in collective impact, we need to develop trust so that we can learn from each other. That's the first step. Then we need to agree about what is important. And that enables us to identify the leverage points that will help us achieve our common goal. And then once we've done that, we have a plan, or we could call it a common agenda, or we could call it a theory of change. We could use any kind of fancy words to say that, in effect, we have a plan that we've agreed on. And then measurement flows from that plan. And when it flows from the plan, then it can act as a navigation system for an initiative. So humility and learning come first when we're thinking about leadership for public health and collective impact, and then agreement, and that's a piece there where public health can really provide a lot of support around facilitating that work, and then more learning, and then measurement comes in after that. And so for us to move on to the next slide here, we've got the needs of the community and the needs of the systems that we designed to serve it. And I won't spend too much time on this one because I know that Hannah can speak really eloquently on this subject. There are a number of ways that this can play out, of course, and it often requires a lot of creativity and persistence to manage this tension well. I'll just give 2 quick examples here. A collective impact initiative, one of the things that can happen is that an initiative, there's so much enthusiasm about the model and about the initiative itself that it becomes monolithic and it starts pulling resources away from other important community-based initiatives that aren't aligned with its vision. So that's one way that this tension can play out. And then another one is that by getting behind collective impact, we actually end up creating an unintentional new bureaucracy to support the collective impact initiative. And then, of course, that bureaucracy needs to be maintained, and we start directing our resources toward maintaining the bureaucracy. And, of course, there needs to be some kind of structure. That's what the backbone function is. But there's a real tension there around managing the degree to which we become bureaucratic as we're trying to do things differently. And then we can move on to the next tension. This here is number 4. equity and efficiency. So we all know that genuine community engagement is really time-consuming. And if we do it right, it can also be really, really disconcerting. In fact, we need it to be disconcerting if it's going to be effective. So in the short term, really and truly engaging with people who have lived experience with vulnerability or with structural disadvantage or both can be pretty inefficient, but it's necessary in order to get to impact. Some people refer to equity as the sixth condition of collective impact, and I'm one of those people. I'm sure many people on this call are familiar with this tension already because it really is at the core of so much public health work. So I won't spend too much time here either, but we can pick this thread up in the discussion at the end of the webinar if people want to discuss it more. All right, last slide. This is my favorite one. I'm so enamored with this tension. All right, so this one is about whose norms, and the second question, which is who gets to feel uncomfortable. One thing we often don't think to question is whose norms determine the structures of our initiatives. These norms can actually be quite invisible to us when we start doing this work together. So this tension includes things like how and when and where we meet. The picture in this slide here is just one example. So this picture is it's a group of youth here on the graph, if you want to find the right slide. So this is a meeting of a group of youth and a couple of adult allies who were involved in a collective impact initiative that I was part of here on the West Coast. And the youth held all of their meetings outside. And when they participated in meetings that adults organized, of course, all of those meetings happened in boardrooms. But when the youth got to be in charge of their own context and their own norms, it was all outdoors all the time. Even when it was raining, they would just bring a tarp. And of course, this is the West Coast, so it never got prohibitively cold, so they were able to do that. But when we start thinking about norms, as I mentioned earlier, ultimately it comes down to the question of who gets to feel uncomfortable. And then the next question is, how do we support partners in a collective impact initiative when they do start to feel uncomfortable? And this is for me where the real learning is and the real richness is. I have a theory that a lot of our change efforts stall right here. When the people who have power in the system get uncomfortable with the changes that are starting to happen, but there is no mechanism for them to access support in managing that discomfort, and so we lose them. So they're still physically present in the room in most cases, but they are no longer aligned. They're no longer moving with the direction of the system change. And this shift can be invisible, so it can be really difficult to identify from the outside because they're still physically present. But if things start to stall, I have found that it's really worth looking into this tension. And as practitioners, we tend to offer support to what we could call the unusual suspects, the people with lived experience who are involved in a collective impact effort, but we rarely support the usual suspects because we assume that they know the ropes and they have sufficient or possibly even excessive privilege and that they can take care of themselves. What I've learned is that all participants in a collective impact initiative that is focused on system change requires support with managing the change process. That really has been my big learning. One of the most powerful forces for snapback in a system that I have observed is the discomfort that those who have historically had the most power and who therefore set the norms and command the allocation of resources feel when that system begins to change, and then they just walk in. So this is the tension between disrupting the system in the service of desired change and offering support to all system actors to manage the personal impacts of that change. Even if it's a white guy with the enormous salary and the intimidating job title, I've learned that he really needs support too with the change process. So I'll wrap up there. I don't really know where I'm at in terms of time. I could talk about the subject all day. I have some more blog posts on this subject, and we can send out links to those. Maybe I'll drop them into the chat there. And please feel free to reach out to me directly if you want to discuss any of this more, or we can also discuss it at the end of the webinar. I'm really looking forward to hearing from Hannah, who's up next, and to the discussion that we've scheduled. Thank you, Petra. Thank you very much. The level at which you are providing guidance and advice is really powerful, and the issues that you're raising, just to give voice to some of those tensions, to me is so helpful. So there is a polling question. It's slide 29. So we're just interested to know which of these tensions that Petra identified resonates most strongly with you. I'm sure there's overlaps, but if you were to pick one, which one would it be? There was a very quick response to whose norms. It seems to be at the crux of system change. And then quite a few people identify needs of the community versus needs of the system designed to serve it, which I think public health is probably very familiar with. Thank you, everybody. So Hannah, starting with slide 30, please. One of the things I learned from Hannah as we put this together is the extent to which the Winnipeg Regional Health Authority is already engaged with collective impact. So I'm eager to hear more.
Thanks, Karen, and thanks to Louis and Petra. It's hard to come after you both in so many ways, but I'll start on slide 31 that says how is WISA involved in the collective impact work. Just to get us going and thinking about, okay, so I've worked in population public health here in the Winnipeg Regional Health Authority. I've got a role where I work at the regional level, but also lots of different community partnerships and organizations. And we are involved in public health and a number of different local initiatives. And what I really liked actually was Louis describing public health role as convening people around the table, and Petra talking about the respect of community and credibility, because when we have been involved in both loose and more formal ways is participating in brainstorming and the framing of the common agenda about making connections between organizations, of championing something to say it's important, and lots, and I'm going to go into this, but meetings and meetings and meetings, because it takes a while, and everybody here with public health knows how long relationship building can take. So, like one example would be what we're calling the PRC 92 is an example there that comes from the Winnipeg Poverty Reduction Council. I'm just going to put in a link in the top box there about that work, where it's an organization outside of ours we're working at, but where there's mutually reinforcing activities where we make connections to Indigenous health within our organization. We're also working on the same metrics of youth employment in recognition for Indigenous youth. So there's just so much going on that it's sort of like we're involved in both loose and formal ways. And then there is a very specific, and it's because of our experience here about this contributing funding, and it could be in the way of in-kind support, but also financial support. And what I found what was most interesting in that NCCDH document was how often it describes NCCDH, how it describes public health as being one of the better resource partners. And we often don't consider ourselves that well resourced, particularly when we compare with acute care. It's very relative, right? But one of the things is that we have been able to provide some core capacity infrastructure support to a group that was well positioned to provide backbone support. So they lack core funding to have staff, and we were able to get some funding to them that they attached to human resource time to make them more of a backbone organization. They hired a community impact or a collective impact facilitator, right? So in some ways we provided that funding, and it was exciting, but as I'll get to later on in the presentation and talk, it's sort of like that comes with something, comes with an understanding and a recognition, and there's some tensions in that. Someone else mentioned that they contribute funding towards training, and for us, the exact same thing of our public health practitioners participating in training, or funding the training itself in order for other people to attend. I myself am personally involved in a network of trainers, kind of a train-the-trainer model. And what we do is we have a community practice for collective impact that regularly gets together, and we actually talk a lot, kind of using a case study approach about how things are going and hearing from different ideas, and there's just lots of overlapping participation. And then the last thing I want to emphasize is just how many different types of partnerships public health is involved in, and that this results in a continuum of things. There's like very specific, following all those rules of collective impact, to something that might be collective impact like, or more a collaboration where we're trying to use and some of our lessons or experience, or just using those principles from collective impact. So one example is we're working on a street health survey in partnership with End Homelessness Winnipeg and lots of other partners. So there's a funding piece to that, but there's also the framing, the data, the common measurement, the common agenda that goes into those kind of partnerships. So I'll move to the next slide, which is 32, and that's just how did we get here, what have we learned? And so I have the experience of working here in Winnipeg with lots of people, lots of effort and dedication before my time. And it's this, again, some of this health for all work is what we call it, began with thinking about the data, and that the organization, our health authority, has recognized the impact of health inequities and the importance of partnerships in that work. So equity is a value of our organization, and one of our longest standing working groups of the Health for All initiative is actually what's called the Health for All Partnership Working Group. And in some ways we kind of struggle to figure out what are we actually doing as a partnership group, but it really did emphasize the importance of partnerships. That's public health at a regional health authority cannot promote health equity alone. And so then they're funding for positions because of that recognition impact, positions like mine, or in-kind or other kind of contributions. For example, my colleague, Dr. Sandy Harlow, a medical health officer for our work, is part of the Winnipeg Poverty Reduction Steering Committee. So she spends a lot of time thinking in partnership with those around the table about trying collective impact approaches. The funding and the resources. So in some ways, because senior leadership recognized the importance of partnerships, that we had a little bit of access to funding. And this is very challenging, particularly right now in times of fiscal constraint, because we know that funding for coordination and collaboration can be targeted for cuts, because the question is, what is the outcome? So again, I'm thinking about that idea of being one of the better resource partners, but we have to be careful about how we get that money to other places, how we can be thoughtful about its use, and that we don't want to have the perception, and this is what the expectation is both ways, that when we do provide funding, we have heard this kind of concern of, well, what is it that you're asking for us? What are the deliverables? Or concern that we're taking over? Or, what is it that we're specifically looking when we're trying to shift that power? But then there's a history of us having the resources and wanting a specific outcome from them. And then the next one there was about building individual capacity to work with both practice. And part of this is that it's there's so many. I missed one about the relationships, and it's tied hand in hand. It is many, many meetings, and we have taken the time in WRJ to have informal agenda-less meetings, to go into the events with others, to network and to build those relationships, clarify issues and avenues. And what we found is that really early is sort of like the building of trust. And there's almost sometimes a tipping point when the partners go from getting to know each other to seeking advice and support. And it's like a very exciting time. There's often myself and my colleagues look at us and say, hey, we just moved from that tipping point. And that tipping point can be helpful, particularly when we're thinking about moving from networks and trust, because what happens is that then it moves to resources. So the next point was about individual capacity and to support this work. Sort of thinking about how we prioritize the day-to-day activities of ourselves to align with the needs of the community. But we've been talking so much in public health about this idea of working to full scope to better respond to community. And again, now that I'm listening to Petra, listening to Louis, there's a little bit about us and our own change management processes of reflecting about where the power differentials, what is it that I'm bringing to the table, to do that self-reflection and learning, and that it's both individual and of the system to be able to make some of those changes. So an example of this, and even my building my own capacity in law and law, and I talk a lot about how health and poverty are related. When someone says, oh, will you write a quick one-pager on that for me to bring to a community stakeholder meeting, it's surprising how much time and energy and effort that can take for a specific item or circumstance. So it's work. And then I really, the comment from Petra about that tension and about what, I put it as a question of what goes in my monitoring report of what do I do? And it's kind of a joke, but it's a real question that we have to ask ourselves about trying to write down the qualitative reflections of what's going on. But, you know, do we write down the number of meetings that we attend or the number of presentations or reports that contribute to it? On the next slide, and I wanted to do this relatively quickly, and I hope I haven't gone over time here, but the next slide is system barriers and personal tensions. And it's interesting hearing from the previous presenters and thinking about how I have framed this and where there's a lot of alignment, is that this question of autonomy and flexibility, and I frame it for myself as can the work be tolerated in the health system. So we, as a regional health authority, might be viewed as a risk-averse organization. So when Petra talks about that idea of experimentation, we often use that language of a plan, do, study, act cycle, right? Like, and thinking about how we actually can be flexible, but also take a quality approach to doing some of this work in partnership with others. This next point is one that I struggle with often, almost on a daily basis, where the work in promoting health equity, when we're talking about being uncomfortable and managing that discomfort, but we're also talking about working in partnership and in different ways. There's political restraints to that, and mostly like the small piece political, but there's also optics of either me being at the front of the room in a community organization or being involved somehow. And so the question often goes to, am I being a coward or am I being politically savvy in whatever way? And so, for example, with the funding that we support to an organization that provides collective impact support, you know, we keep it as a low profile. So to the point, like, can we talk about it on a national webinar? Because we want to hold on to it, or are we being, am I being a coward about that? Or if I'm working behind the scenes with a group that's in the news, or if I'm contributing to a job report, but I don't want to be recognized. Is that savvy, or is it being a coward? The next point is something, and this again, one of the tensions that Petra mentioned about the idea of efficiency and equity and building relationships. And I've been to meetings where I'm a well-paid quasi-government staff, and I'm asking a very busy community-based organization staff to tell me about their work, to have a coffee, and they're running a program on the side, or have another thing that they're trying to respond to, you know, and here we're trying to develop a relationship. So I do this, you know, we leave the meeting and it's like, I really hope I'm not wasting their time, but I don't have a real outcome at the end of that informal chat. But we know each other a little bit more about something that could happen in the future. And then this last one is one that I touched on previously about funding and roles and power differentials, and that organization, you want it to be neutral, but with funding can come expectations, particularly historically, and thinking about how we're trying to be so accountable for all of those dollars that are spent. And that really ties very much into wanting to the points about being constrained or the object or even our public health autonomy. So that was the last of me in that last there. So maybe I can pause here. I didn't have a poll, but we can have some questions, and then we're going to open up the discussion.
Thank you. Hannah, thanks so much. I think there were many parallels there with, well, among all of you, and really helpful dialogue between the three of you. And I'm trying to encourage people to send in comments and questions and their experience. And just hearing from Heather King, some public health units are municipally run and are not allowed to lobby to the government. This is why being part of a collective is so important. So I don't know if anybody has, any of the three of you speakers have a response to that, but just on understanding how collective impact can help strengthen or add the advocacy voice, I guess, for everybody in it.
It's Louis. Thank you, Hannah, very, very much for what you shared. I join with you on a lot of the tensions and a lot of the struggles that we face in the healthcare system around doing equity and collective impact and really grounded population public health. I recall, Hannah, and I posted it in the chat space there about, remember the day and the time in WRHA when we had to face those uncomfortable truths about people who were living in the margins, dying 19 years earlier, the inquest that occurred around the death of a vulnerable person, and how it was so central to the shift because we couldn't deny it or we couldn't pass it off anymore. And that was a moment of opportunity for us to use it as a transformative dialogue. And the role that public health played in that.
Yeah, I think that's a real point, Louis, because one of the things, and I put it up on one of the slides, is some of the Health for All work that we did within the WRHA, and much of it before my time with the region, say about the position statement of recognizing those health gaps and saying, in the position statement, it states very much that we're going to partner with others to reduce those health gaps, and that, for my point of view, is that collective impact is one of the approaches, one of the principles that we can do in trying to apply that work. But it did start with that acknowledgement of the data, the large health gaps.
Exactly. And it was something that was used as a moving forward document rather than a problem-centric kind of discussion. It was about we need to move and change rather than pass blame. That we no longer could just see it as an external social issue that caused this. That we had a responsibility, an ethical responsibility, but programmatic as well, to actually look at equity work and collective impact and change our practice because we were part of the cause.
That is that's certainly a moving forward position to hold, Louis, and I'm admiration that you are there with it. And Petra has just asked if you would say a little bit more about what you mean by guerrilla public health work versus integral public health work.
Integral public health work. I come from a clinical social work background. One of my masters in that, and we talk in social work, and I think it's very, very adaptable, and it can be applied to public health as well. The whole issue of, is this part of what I do, or is this something that I need to do to infiltrate the system that I'm part of, but that is actually perpetuating structurally and systemically these issues, and I need to infiltrate it in a way. This has to be outside of my work because I need to use other venues, other avenues, other pathways that include community in order to get this work done. because I need to stay under the radar in a way, because the system eats its children, right? In a way that if you don't, it's structurally set to sustain itself beyond what individuals can do. So in social work, and I think in public health, and it's a dilemma, it's a tension for a lot of people who are practitioners saying, you know, we need to do this, but how can we do it? And what is our role in public health to actually create a movement for change that we are ripening, or we are in a way an ally and encouraging that will actually come back to have an impact on the system we work in.
And Louis, there's another, I think this question would be for you from Manish Kaur, asking if the homeless health guidelines, which you probably know about, are influencing public health strategies or other policy areas.
I am not fully familiar with the homeless health guidelines. I have a group that's working, and Hannah touched on it, around the street health survey that would be more familiar with that, as far as you know, approaches, practices, and structures that are more adapted and more suited and have better outcomes for those who struggle with health issues because of their homelessness. It should feed into the public health strategies for sure. It should feed because, and when I say public health, it's at the unit level, and it's the role that public health can play to be a leader and a carrier of evidence around all of nursing and all of the health work that occurs within units and programs, and in an integrated way. It should affect home care. Public health should have the courage to affect home care, mental health, primary care, acute care, and long-term care. There's a role for public health to actually be the conduit for change for this population. We had a very good discussion yesterday in our community around end-of-life palliative care and homeless, and that's a public health issue in Manitoba and Winnipeg, around what the care and the options are. Although everyone is saying we serve everyone at end of life equally, there's a fact that these systems are not designed to respond to the unique realities of many of the individuals who struggle with homelessness. So it does become, management does become very important that you take an integrated strategy around this stuff to look at the policies in practice and how these need to change.
Manish just elaborated there a little bit that it was work by Kevin Covey for Canadian Doctors for Refugee Care group that I guess has written these guidelines.
And I've cut and pasted your comment, Manish, because I'm going to go look at it to make sure that we've integrated it into our design team that's looking at that street health stuff for this population. Thank you for that very much.
You know, the question that's been coming to my mind for Hannah and Petra, I guess, is, although Petra, I suppose you haven't worked within public health and outside of public health, but it is I don't know, in sort of, maybe as a way of kind of tying things together, if either of you have comments about what's easier or what your experience of how the leeway people are able to have perhaps working for in community organizations than working for a more formal public health sector. Don't know if there's anything in that where the maneuverability is, I guess.
Karen, I would be happy to speak to that. Are you sort of, as you're asking a question, what I'm thinking about is the tension that Hannah identified between, what she said as being a coward or being politically savvy. Is that sort of what you're getting at?
Yeah, I think so.
Okay, yeah, I think that is something that because I've always worked with public health, but outside of the public health
system. And so that's something that I know that a lot of people have to consider, no matter what organization they work for. Any large organization like public health, there are additional layers, I think, that come up for people when they have to work inside a system like that. And it's quite paradoxical, I think, because sometimes it feels to me, and I'm an outsider, and I would love to hear from Louis and Hannah about this, but it sometimes feels to me as though in order to fulfill the mandate of the organization, in this case public health, some of the actors inside that system, people who are employed by that system, need to actually go rogue a little bit, perhaps go guerrilla, and actually start behaving in ways that are somewhat subversive in order to fulfill the mandate of the organization itself. And so that's one of these really interesting tensions that I think really comes up for people, or I've observed that may come up for people who are working inside that system. But I think it's also relevant for those of us who work outside the system, because it is always, I think it's always awkward. It's always disconcerting. And potentially it's always painful to some degree to actually engage in real system change and to engage really authentically with people. And no matter what, it is political. We are always managing our own personal needs with the needs of the group, and we're always kind of in that place of tension and having to evaluate when it's appropriate to speak up, and when it's appropriate to step back, and then if we're stepping back, are we doing that because we don't want to engage with that discomfort, or is it because we just want to be humble and we want to let the group kind of make its decisions without undue influence? So I think that there's a lot there, and I would love to hear from Louis and Hannah about that. Sort of that sense that I get about needing to be subversive in order to fulfill the mandate of the organization.
Petra, you asked some really very important questions. And, you framed them so eloquently. I think if I'm looking from an Indigenous framework, and I practice traditional Indigenous approaches, I think the role of public health is about being a firekeeper. That if we can't be good firekeepers, others can't do their work. But sometimes that means also protecting the space in which the work needs to occur, and that can be subversive in the sense of we know that if we're too visible with this work, that there could be consequences. In a sense, and it gets personal, but all politics are personal, right? And so if it's about enhancing or giving space for the voice of those who are really marginalized, who don't even trust, and that are disconnecting, rather than actually being empowered, that journey of empowerment is powerful, but it's also a lot of work. So how do we keep that fire? How do we do that work as public health? And that's community work. That's public health work. Because we've got to bring the tools in order to have a healthy fire. We've got to create a safe space, and we've got to manage it. And those are skill sets that we need to cultivate in public health and within our community. You can't ask someone who's sick to take care of a fire. They have to be strong enough. They have to have some tools and some support. And sometimes we have to realize that we're the ones that are sick. So it's an analogy, but I think it's complex, and that's what collective impact is supposed to be. We shouldn't shy away from that, because at the end of the day, if it doesn't transform us, we can't ask it to transform anyone else.
Thank you. In terms of eloquence, Louis said as well, and certainly that idea of having to go rogue to fulfill our organization's mandate, I certainly can identify that from our position at the NCCDH and how we're looking at going forward as well. Helpful advice. And anything to add on that one, on that note?
Yeah, and for me right now, Petra, I'm reflecting on your comments and thinking about, managing this learning zones, that there's just so much that can happen. And at the same time, I ask myself about being, politically savvy is because we are working within our organization's mandate, that we want to be accountable and that we want to keep that credibility that you mentioned that brings other people around to the table. So figuring out the data, the community knowledge, that there's just so much in that balancing act that when you're involved in a collective impact initiative, that we're working hard to balance, basically, and all those tensions of thinking about individuals at the table and keeping the population level view at the same time. That's where I'm trying to get about, and I frame this as personal tensions and assistance barriers, about public health, and even if it's a regional health authority or if it's within a municipal structure, that we're quasi-government, that we're funded by the political bodies who run the government, and that they come with their own ideologies and approaches, and that what we're trying to do is figure out, either in the intentional or guerrilla, or depending on the opportunity, about how we make sure we use the data, the evidence, the community voice in that process. And it's an art and a science. And it takes a lot of time and resources, and I'm thinking about running in to do a webinar and running back to go to another meeting and then running somewhere else, where you're trying to be credible, and also there's so many issues and system changes that are required. Thinking about collective impact is one way where we can really focus with partners on a common agenda. So that's where my brain goes, but I'd be really interested to hear from other public health practitioners or other people who are partners with public health who might be on this call if they have other questions or their experience of working in these ways, what they've kind of used as tools to help in that art and science.
Thank you, Hannah. And I don't know if we will send out a report with all the links and slides to everybody after the webinar, and with the email address with Hannah's email and pictures and Louis as well. So please, at another point in your days, if you want to be in touch with anybody, I'm sure they would be delighted to hear from you. And I have, there's a couple of questions coming in at the moment, but I've also just said that those of you who can't stay, there is an evaluation form. We would love to hear your feedback. And if you could fill out that form, we'll also send that by email to you too. So yes, thank you everybody. It's been a rich discussion, and I hope you've gained something from it, and I guess most of everything. I hope that it is helping to encourage you to continue with the work you're doing with collective impact, and I wish you all the best with that work, and please stay in touch. Where we, at the NCCDH, we feel that this is a really important area for us to be following and